I call upon Dr. Dipti to present the correlation of glycosylated hemoglobin with retinal nerve fiber thickness and central macular thickness in the diabetic population in North India.
Requesting all speakers to stick to their time and requesting the next speaker to come to the podium during the discussion. Up next is Dr. Sachin Rohela. Thank you.
Good morning, respected judges and delegates. I'm Dr. Dipti and my AIOS ID is D27136. And I'm going to present my study on correlation of glycosylated hemoglobin with RNFL thickness and central macular thickness in diabetic population. Diabetic retinopathy affects nearly 90% of individuals of diabetes, and the American Diabetes Association has recently defined diabetic retinopathy as highly tissue-specific neurovascular complication involving progressive disruption of interdependence between multiple cell types in the retina. HBA1C can also be used as an effective tool for diagnosing patients who are at high risk to develop complications, including retinopathy. So the aim of my study was to correlate HBA1C level with RNFL thickness and central macular thickness in the diabetic population in northern India. My study was a cross-sectional observational study done in Regional Institute of Ophthalmology IMS BHU over 450 patients over a duration of 18 months after proper committee ethical approval. All the participants were divided into 3 groups. The first group was healthy controls with no systemic or ophthalmological issues. Group 2 included patients with less than 7 years history of diabetes and without diabetic retinopathy. And group 3 included patients with more than 7 years of history of diabetes with mild to moderate NPDR. The inclusion criteria being patients with type 2 diabetes and age above 18 years, and exclusion criteria being best BCVA below 1 logMAR unit and other causes and other associations causing RNFL loss like myopia, severe retinopathy, severe NPDR, PDR, glaucoma, etc. So the first fasting blood sugar, postprandial blood sugar and HbA1c were compared using unpaired t-test between patients with no diabetic retinopathy, mild to moderate NPDR and control group, and later any correlation present between HbA1c and 4-quadrant RNFL thickness and CMT, central macular thickness, was found and correlation graphs were plotted. Coming on to results, we found in the baseline characteristic features of the participants, we found there was no significant difference between the mean age and gender of the patients between the 3 groups. However, there was a significant difference between the best corrected visual acuity of both eyes, fasting blood sugar, postprandial blood sugar and HbA1c levels. On RNFL thickness, we found there was significant difference in all the 4 quadrants of both right eye and left eye. And then we did correlation graphs. We found no significant correlation in group 1 between HbA1c and RNFL thickness, and in group 2, that is diabetics without retinopathy, we found significant difference only in inferior quadrant of left eye, and in diabetics with retinopathy we found significant difference in inferior and superior quadrant of right eye, inferior, superior and nasal quadrant of left eye. And these are the correlation graphs between right eye 4-quadrant RNFL thickness, which is showing a negative correlation. And this is also the correlation graph between left eye 4-quadrant RNFL thickness and HbA1c, suggesting negative correlation. Coming on to central macular thickness, we found significant difference between the 3 groups in both right eye and left eye, and then the correlation was plotted. We found there was weak positive correlation in the diabetics with retinopathy and without retinopathy, but which was not significant. And this is the correlation graphs between bilateral eye central macular thickness and HbA1c of group 3, that is diabetics with retinopathy. Coming on to discussion, Mehboob et al. Found that the mean RNFL thickness and RNFL thickness of 4 quadrants both was found to be significantly thinned out in diabetic population. Dasmana et al. She found significant RNFL thinning only in superotemporal and upper nasal sectors in patients with retinopathy, while our study suggested RNFL was thinned out significantly in all quadrants of both eyes in diabetic patients. Oshiatari et al. Found the CMT was significantly thicker in pre-proliferative retinopathy and then that of the no retinopathy group. Jamali et al. Found CMT to be increased in with increasing stages of retinopathy and by bad glycemic control. And our study also suggests the CMT to be significantly increased in diabetics irrespective of the state of retinopathy. The limitations of my study were that RNFL thickness and central macular thickness were evaluated at one point of time, and long-term follow-up was not done, and also the ganglion cell thickness was not analyzed. So we concluded that RNFL was found to be thinner in patients with diabetic mellitus when compared to control, with statistically significant difference, and CMT was also found to be thicker in diabetic patients with statistically significant difference. However, the study indicated a negative correlation between HBA1C and 4-quadrant RNFL thickness in diabetics with retinopathy, and we found weak positive correlation between HBA1C and CMT in diabetic group with or without retinopathy, which was not significant. So my take-home message is monitoring RNFL thickness could serve as an early indicator, and glycosylated hemoglobin also indicate about RNFL health. These are my important references. Thank you.
What was the reason for doing this study? I mean, how does it add to literature which is already there, and what is the clinical correlation that you want to derive from this? What's your take-home message from this?
Sir, the take-home message is while we do HbA1c level, we can correlate with RNFL thickness, and also we found no such literature in the northern India population correlating